radiologists that will arm you with an action plan that will allow radiologists to take a leadership role in shaping the future of healthcare. Tonight's session is based on the case study, The Network Effect, which features Dr. Robert Pyatt, President of the Chambersburg Imaging Associates in Chambersburg, Pennsylvania. Dr. Pyatt is joined by Carla Rice, Diagnostic Imaging Manager at Chambersburg Hospital as well. We are very fortunate tonight to also have Dr. Geraldine McGinty for our moderator. Dr. McGinty is Assistant Professor of Radiology at Weill Cornell Medical College and Assistant Attending Radiologist at the New York Presbyterian Hospital Weill Cornell campus. By participating in tonight's presentation, you will have the opportunity to earn 1 Level 3 elective RLI credit. You will receive an email tomorrow with instructions about claiming this credit and an email in a day or two with a link to tonight's recorded session. Before I turn it over to Dr. McGinty to get things started, I wanted to quickly review 2 housekeeping items. Tonight's presentation is scheduled to last about 30 minutes and will be followed by a 30-minute Q&A. Please feel free to submit your questions at any point during tonight's presentation by typing them into the questions pane. Your questions will be addressed at the end of the presentation. And if you have any questions now or at any time during tonight's session, or if you happen to experience any access issues, please feel free to type your question into the questions pane as well, and someone will assist. Again, thank you so much for your time and interest in this exciting series, and I'd now like to turn it over to Dr. Geraldine McGinty to get the conversation started.
Thank you so much, Anne-Marie, and thank you very much to all of you who are dialed in this evening. I hope that many of you were at the ACR 2015 meeting last week. It really was a great event, our kickoff all-member meeting. And for those of you who weren't there, you missed a great one, so we hope to see you in 2016. And I'm really thrilled tonight to be moderating this webinar with my friend and colleague, Dr. Bob Pyatt. And Bob has been a really effective chair of our Economics Committee for the General, Small and Rural constituency, and is now moving on to bigger and better things. He is now vice chair of that commission and also taking on additional responsibilities around quality and safety. And also, many of you know, he's been a leader in our RAD-peer activities, among many, many other contributions to our specialty. And I haven't had the chance to meet Carla in person, but delighted to have the perspective of Bob's counterpart on the executive side, on the hospital side, to talk about the really innovative work that they've been doing around networking. But we're going to cover tonight a few basics around Imaging 3.0, and I really hope that there's not a single person on this webinar who hasn't heard about Imaging 3.0 at this point. But really importantly tonight, we're going to talk about how you as a practicing radiologist can employ Imaging 3.0 strategies to enhance your practice. And, you know, based on hearing real stories from people like Bob, and I'll just say that to remind you all that Bob's story is captured in an excellent case study and actually also in a video. It's one of many case studies that we have on our ACR Imaging 3.0 website. They're really great stories of radiologists like us making change and implementing Imaging 3.0 in their practice. So in case there's anybody who we haven't talked to yet about Imaging 3.0, what is it? Well, essentially, it's our game plan for the future. And the quote in the upper right here comes from Viv Allen, our current board chair. Our fundamental goal is to deliver all the imaging care that's beneficial and necessary and none that is not. And Imaging 3.0 essentially has 3 main actions. It starts with a culture change in terms of how we perceive ourselves and how others perceive us. It's a very important portfolio of IT tools to support that culture change. And then it's alignment of incentives, alignment of payer incentives and quality incentives to make sure that the care that we're delivering is actually recognized and valued in our healthcare delivery system. And it's about taking us from being volume-based to value-based, about taking us from being transactional radiologists who are just trying to get through the work list and trying to bump up our RVUs, to really bringing us back to being a consultative specialty. Very importantly, it's about making our practices patient-centered rather than centering them around our own schedules. And as we transition to an entire healthcare delivery system that's focused on quality and value, it's about making sure that we look at the outcomes and we track the outcomes of the imaging that we interpret. And our goal is really to make sure that we do not become further commoditized and that we take our rightful place as integral an integral part of the healthcare delivery system and of the healthcare team for our patients. And obviously takes us from being the invisible radiologist, taken away from our clinical colleagues and our patients by our really efficient PACS systems that mean we can read anywhere, taking us away from being invisible and making us accountable. So somebody who embodies really all of the principles of Imaging 3.0 is Bob Pyatt. I'm going to turn it over to Bob now to talk to you about the network effect, talk to you about the real successes that he's implemented in his practice. Go ahead, Bob.
Okay. Thank you, Dr. McGinty. Carla and I are pleased to be here tonight, and take it to the next slide here. So we're going to talk about the network effect and how radiology practices, large and small, can use the power of the network to create new opportunities. According to standard definitions from economics and business, a network effect is the effect that one user of a good or service has on the value of that product to other people. To create a network effect, you must work to increase the value of a product or service by increasing the number of people within the network. The telephone is a perfect example. The more people who own phones, the more each individual person stands to gain from owning a phone. For 2 decades, the folks here at Chambersburg Imaging Associates have been working to build and leverage the network effect by pursuing innovative ways to maintain strong face-to-face communication with our referring providers. The more connections we forge to build our network of referring physicians, nurse practitioners, office managers, and others, the more each person in the network benefits. Tonight we'll be talking about how to create and leverage the network effect. At Chambersburg Imaging Associates, we've generated the network effect with this innovative educational program that we'll be talking about. Before we get started, let me tell you a little bit more about Chambersburg Imaging Associates, or which we call CIA. We're the other CIA that you may not have heard about. You might think that a network effect is only possible in a major city at a large radiology practice working within a massive health system. But we're here to tell you that a dedicated team and an unswerving focus on education, any size practice can leverage the power of the network. So let me tell you a little bit about our group. CIA is a small 9-person radiology practice that started in Chambersburg, Pennsylvania about 25 years ago. We are about 25 miles west of Gettysburg in south central Pennsylvania. Since then, CIA has expanded to serve the 2 hospitals in our county and the various numerous outpatient centers throughout Franklin County, Pennsylvania. And the high quality of our CIA radiology services also draws patients from some of the neighboring states like Maryland and other counties. We work closely with regional medical and surgical specialists to provide accurate diagnosis, consultation, and intervention. Our departments use state-of-the-art equipment that is equal to or better than those found at many major academic institutions, and this results in the highest quality images with our most accurate diagnoses. CIA is part of Summit Health, which is a nonprofit independent health system located in south central Pennsylvania. We service about 175,000 people. So we are small, but we are mighty in our approach to refer education. So let's talk about how we first began this program a little over 2 decades ago. A lot of things have happened in the last 2 decades. The PACS certainly has contributed in a big way to the disconnect going on between clinicians and the medical staff and radiology groups. So we just don't have the conversations like we used to years ago. Other things that have happened too, you have the primary care physicians who used to round in the hospital. Well, they don't do that anymore. So you hardly ever see the PCPs coming through like they used to. And the hospitalists are there now, and we just don't have the level of communication throughout the medical staff like we used to because of, in large part, because of the PAC system. So the suboptimal communication that is going on has created these divides and gaps and issues which can occur between diagnostic imaging and various members of the medical staff and associated offices. And it causes misunderstandings about imaging orders, appropriateness of the procedure, the results, interpretation of the results, And not only that, but also diagnostic imaging procedures have gotten much more complex. There's so many more procedures we offer nowadays than we had 20 years ago. And yet the ability to communicate these to the referring physicians and their staff has just been not as good as it could be. So over the last many years, we've tried to address that by our educational teams that we're going to talk about here. There are also a number of new members of our practice that have joined over the years, and we want to get them to be able to meet key members of the medical staff. So that's another reason we have these programs. And in addition, so we're trying to bridge this gap that has been created over the last many years, and we're trying to address that with these educational teams. So we've been exploring initiatives to increase radiology's value in a variety of ways. And we've had, for example, sessions which we'll talk about here in a minute with OBGYN and family medicine groups and other specialists like the orthopods, the oncologists, pulmonologists. When we have new procedures that need to be introduced, we use this educational effort to introduce new procedures and new radiologists, and it's been very helpful to us. See next slide. So we began visiting referring clinicians' facilities in the area to deliver lunchtime presentations. And in the past year, we've had a number of sessions, which you see on your screen there. The lung cancer screening program has been very successful. We've taken that to a number of different locations at both hospitals in our county, a number of different groups associated with the hospital. And we've really seen our lung low-dose screening program take off. We've actually had, at quarterly medical staff meetings, we've had the pulmonologists stand up and give, this is unsolicited, they stand up and give us testimonials about what a fantastic low-dose screening program we have and about the cancers that we are finding already. We've had several, and it's been very successful, and it's nice to have the pulmonologists speaking, openly to the whole medical staff at meetings about this valuable program. We've also had issues with breast density. That's been a very hot topic in the last couple of years, and a law was passed in Pennsylvania last year in January, and we've had a number of sessions with various medical groups around the county to educate them on breast density and the role of breast ultrasound and MRI, and we brought mammograms showing fatty breasts and dense breasts to have a visual impact as we do these presentations. It's been very helpful to have the visual piece. And some of the sessions, the ones that I go to, I'm very involved in CME here in our health system, so I've been able to get those programs accredited, and the participants at these programs can earn up to 0.5 hours of Category 1 credit, which is helpful. It does increase the attendance a little, and I think adds a little extra value to the program. And if you have a CME program at your facility, I would just go to the CME committee and ask them to work with you to get your programs accredited for either 0.25 or 0.5 hours of Cat 1 credit. Any free credit is good. So other issues that we talked about, for example, we've had issues with OBGYN with the reporting formats and issues relative to standard ranges and so forth. So some of the members of our group that have that particular interest have gone to the OBGYN department and have worked with the OBGYN staff to improve our reporting formats so it's more what they like to see and formatted the way they like it, and then we standardize that within our practice, and that's been very successful. I'd like to ask Carla Rice, who is the director of our ultrasound program here, a manager of ultrasound, have her jump in here and make some comments about her perspective and how she sees this helpful.
Hi, my name's Carla Rice, and I'm the diagnostic imaging manager in charge of ultrasound here at Chambersburg Hospital. The lunchtime meetings have become such a good way to meet everybody that is involved in the provider's office. in addition to having the providers present, we also have nurse managers and the medical records staff and some of the nurses staff, which gives us a well-rounded look at what the provider offices are looking for. When we set up these meetings, we look at the logistics of it, as in we have found that the most successful thing is to actually go to the office and take a lunch with us. We usually try to stick to one topic, one main idea, and then we are open to discussion as far as what the providers are looking for, in addition to what we may be trying to present. So it turns out to be a give and take type of meeting. Some of the things I could say about the meetings, probably the first thing would be when we're setting up a meeting like this, you have to be flexible. It's pretty tough to get a day where both providers, as many providers as possible from the office, and a radiologist is available. So this usually doesn't happen in a week's time. Many times it may take 6 weeks to 2 months in order to get a day when you can get a lot of the providers available. But I think that's well worth the wait. The key is to get as many of the key players as possible together to make it a more valuable meeting. And as far as the topics, in addition to as Dr. Pyatt had mentioned, it may be some new services or legislation, something like that. But a lot of times it also can come back from feedback from the offices, maybe something they're concerned about. Maybe they're getting feedback from their patients that there's maybe a service that we're not providing, or patients are having difficulty with preps or scheduling. And so we, like I say, some of the topics are actually come from the offices themselves.
Yeah, it's really important to keep the program brief. So you want to focus on a particular topic. Try not to make it too broad. Make it really focused. Make sure before you go to the office that the team has, researched this, coordinated their efforts, so everybody knows exactly what the issue is. Keep it short, no more than 30 minutes. You don't want to go any longer than that. 15 minutes is fine also. And then you want to allow time for questions and answers. And then we often like to throw out somewhere near the end of the session, what are your biggest issues with radiology and how can we help you? That will often, at that point in the program, give us multiple ideas of issues that we can address. Sometimes it's a quick answer that we can solve right there. Sometimes it gives us the opportunity for another future session. So we will, we'll say to them, hey, these are great issues. We will develop them and get back in touch with you for a future session. And also by having the manager of the department, the specialty area with you, and the manager for the office, those two people can work behind the scenes and get a lot of things solved in the interim. So it's very important that you keep them focused and fairly short, and get that broad-ranging question out for the chance for future programs. And also, these programs, by the way, are not very expensive. It's usually a brown bag thing. Everybody brings their lunch. Occasionally, we will bring pizza or something like that. But most of the time, everybody just brings their own lunch, and people are coming in and out during the sessions if they're busy with some patient issues. But it's very pretty much informal like that. I think that's helpful. And you want to make sure, like Carla said, that the key people are there. If there's certain really vocal people in that practice, you want to make sure that they are there for that session. You don't want to have a session if some of the most vocal people are not going to be there. You need to hear what they have to say. Now, how do we pick these topics? There's a variety of ways we do this. Some of them is related to feedback that Carla may get or the department manager may get from offices. And other ways, we have this program called the Medical Office Manager Network, which is a monthly program to all office managers of the system. And that is a great way for us to see if there's any issues cooking in diagnostic imaging that we need to address. and you'll know specific offices and people to contact. It's very helpful. Also, if we have new procedures that we're rolling out or new issues that are common to all the practices, that's a chance for us to meet with that group and let them know. So if there is such a group in your health system, you want to be getting on their agenda and finding out issues that involve DI. So over the years, we've developed a number of great relationships with various types of specialty practices, and it makes it easier each time you do a good one and it goes well and things get solved. It makes it easier for the next one to occur. The physicians, the mid-levels, and the office staff know that things are going to get solved. And the other key piece is that we go to their turf. So wherever their office is, they don't have to get in their car or go anywhere. We come to them, and we keep it brief so we don't want to consume their whole lunch hour. And we go to them. That's a very important piece. Carla, I didn't know if you had any additional comments you might want to say relative to that.
As far as the Office Managers Network, that in our world at least, it may take 2 or 3 months to get on the schedule because they have a limited number of topics at each session. So if there is something that we need to know, we move on that quickly so that we can get into the manager's meeting while it's still a relative topic. When we go to the manager's meeting, we usually have two radiology managers there. We do not always have a radiologist with us at the manager's meeting. And what I do want to say about that is I do not think that the office managers meetings are as effective as the going to the offices, because at the office it is physician to physician in addition to nurse managers, office managers. And I think that having the cohesive group, I think more gets done.
Yeah, and I would say bringing visuals. If you do have visuals, bring them, but don't bring too many. You don't want to have a 50 power slide PowerPoint presentation. You want to do that. But if you have a few visuals, it's very helpful. Handouts are helpful. You'll also find that you will develop in those practices contact people. Certain members of that group will be sort of your contacts. So like Dr. Lewandowski, one of our lady rads, has some personal contacts in some of these groups who she can talk to, and that physician in the group can then talk to the rest of the group and get back to us on things. It's a great way to develop relationships between groups. And the administrative people are really critical to taking the issues back home and working behind the scenes to get things solved. Okay, so let's talk about some other aspects of this that might come up. We want to make sure that you have these individuals and nurses, the nurse managers, office managers, medical record staff, support staff. It's very important to have them involved. They think of issues related to DI that the medical staff might not think of, but that are important issues. So it gives us a way to be comprehensive in terms of identifying the various issues from different perspectives. And support staff like the chance to meet the radiologists and the management team also. It's a helpful method. So we call our little group these like educational SWAT teams. You know, they're a highly focused group of people. There's 2, 3, or 4 of us. We train in advance before we have these sessions. We're in and out in less than 30 minutes. We accomplish our critical mission, we hope, and which most of the time we're pretty good at. And we consider ourselves sort of like a SWAT team. So long term, these interactions result in some really nice relationships between the various groups, and it also allows some of the new members of our practice to get to know some of the groups. They might go along with one of the more seasoned members of the group. For example, recently with orthopedics, we have a new member of our practice joined us a year and a half ago, and so he went with one of the more senior guys in the group to the orthopedic group to talk about MRI issues and MSK, MRI, and so forth, and to meet the new member of our practice. So it gives you a chance to introduce new members and get them used to the culture of our group. This is a cultural thing within our practice to have radiologists participate in these programs in whatever area of interest they have. And it also helps to develop our role as a consultant with the referring physicians, not just a rad who's somewhere behind the scenes cranking out reports. We want to have a relationship and be available to consult and discuss issues, and these programs give us a great way to do that. So some of the numbers over the years in our practice in recent years has been maybe 6 different radiologists that have participated in this program, some of whom are retired now. Some of them were very active before they retired. And we've had maybe 16 different topics over the last 10, 15 years, 70 sessions, and some of these sessions are repeats. So breast density, for example, was a very popular one. We had several sessions with different groups on that. And we have probably presented at over 40 different locations throughout Franklin County over many years. And you start adding up all the different physicians. There's quite a few physicians. Some of the sessions are large. We may have 20 physicians there. Some of them are small with maybe only 3 or 4, something like that, depending on the practice. But we have, over the years, we have a definite impact, and we are going to continue to keep doing this because there's always new opportunities to interact with medical staff, solve problems, get to have new people in the practice be known and available. One of the things, too, that spun out of this was the referring physicians were like, well, how do I reach you if I want to get you? How do I, what's the easiest way? I don't want to just call main X-ray and be on hold and so forth. So we developed our radiologist schedule to have the extension each day where that rad is. So if you need to know where the neuroradiologist is or the IR guy or whoever, we know what extension, you can look it right up. Makes it real easy. Likewise, maybe Carla, you might want to talk about that.
There's the flip side of that is we also have been able to, in speaking face-to-face with the providers, get maybe a direct line phone number to them so that you're not wasting the time of being on hold and going through a receptionist and then the nurse and then finally getting a provider. If we just have gotten the direct lines to the doctors and have been able to save time for our radiologists that way.
Yeah, you get that private back number that gets you right in. It's very helpful. Yep. So this program over the years has strengthened the visibility and credibility of the radiologists. We want to be consulted and make ourselves as available as possible and easily reached. It has helped the relationship of our practice with their medical staff greatly, and we enjoy a very high satisfaction rate with the members of the medical staff and with our hospital and health system. And we've had no issues with contracts or any of those issues. I know many groups these days are experiencing issues with their hospital contracts. This is well liked by the administration in addition to the medical staff in their offices. Relative to the lung cancer screening program, that has been very successful and continues to grow, and we're finding these early lung cancers, and the pulmonologists are standing up for us and saying wonderful things, which we appreciate. We've also had quite a nice increase in breast ultrasound and breast MRIs, and we've detected a number of early breast cancers that we never would have seen had it not been for those procedures. So lessons that we've learned from all of this is to provide access to relevant information. We want to make it real easy for them to get information about our services and for us to find out what their issues are. We include a member of the management team always to address issues and concerns and provide a response and follow-up.
I think that the follow-up is a very important part because the providers want to know that when they take the time to voice a concern, that someone's going to circle back and make sure that we have followed through with the discussion. So usually about maybe 3 or 4 weeks after our meeting, I will get back in touch with either the office manager or the nurse manager to make sure that our efforts have come through.
Yeah, I would say the follow-up is critical because if you don't do the follow-up and then you want to have a program the next time, and, you're not going to get nearly the response. You got to do good follow-up and you got to solve the problems, and they will like it, and then they will want you back again. You got to really build your credibility with the practices. And again, we want to stress, keep the presentation focus narrow and and flexible in case you have time to discuss it during the presentation. We've improved the quality of our reporting and satisfaction with our services a great deal, and it's it's a work in progress, really. We're always looking for ways to improve it. And we try and, before the meeting, by talking to the office managers and people in the practice, we try and anticipate whatever the most likely questions and concerns are that they'll have, so that we can have the answers well thought out and good solutions thought out, or that we'll develop with them. So that's important to do your research in advance, and it's important to have open and frank discussion. You need to be aware that you will definitely get some negative comments, and you need to be able to stand there and hear the negative stuff, because that's how you learn to adapt and improve your service, and show that you care to make things better.
And another thing is, after we have these meetings, we then take back to our radiology section meeting a synopsis of what went on, so that all of the radiologists then know what was discussed at the meeting, so that, again, everyone is on the same page.
Yeah, that's a good point, right. And whatever we learn, like from one OB practice, might be valuable to other OB practices, so we learn and convey that same information to other places. So to start your own program, you want to identify the topic. There's various ways you can do that. We talked about the medical office manager network. We talked about feedback that the managers may get, or the radiologists may get, just in general conversation with those physicians. Things may come in from public relations. I mean, there's various ways information comes in to give you ideas. You want to get the right manager for that modality, and the right radiologist who's interested and knowledgeable. You want to understand the issues through research before you have the program, so you can understand the precise issues that are going on. You want to make sure that the key people are going to be there, and if you have to wait a few weeks before they're there, then that's what you need to do. And then afterwards, you want to make sure you follow through and make sure that everything that was agreed upon in the meeting, whatever issues there were and changes that were decided and created, that they're implemented. And then, like Carla said, we communicate all of this to all the members of the department at our monthly meetings. Some of the things that have spun off from this are kind of interesting. Some of the family docs have expressed a lot of interest in shadowing with a radiologist. They are like, well, there's so many tests these days, and how do I know when an MRI is best, or CT, or an ultrasound? So we're working on a program with them, so they would sit with us and shadow with us while we do our work, and get a better understanding of the appropriateness of imaging ordering and the role of advanced imaging, and they believe that will help them a lot in terms of studies they order and better care for patients. Also, we've been approached by the mid-levels and physicians who are working in our urgent care centers. We are having quite an expansion of urgent care centers by our health system, and the people that work in that need training for their preliminary readings for wrist x-rays and chest x-rays and stuff like that. So they've approached us, can they sit and shadow with us and learn things too, and we have agreed to that. So when I'm on call at night, they'll sit with me for a couple hours and see all kinds of pneumonias and fractures and stuff like that, as well as the role of advanced imaging and when it's appropriate. And with them, we're creating our own little teaching file for them, so they have a lot of interesting cases that they can look at, and which will be part of their credentialing, actually, when they get checked for their competency and so forth. So there's been some other things that have spun off from these programs that are kind of interesting. And yep.
Thank you so much, Bob and Carla. That was a phenomenal presentation, and right on time. So what I'd like to do now is start asking you guys to address some of the great questions that we've had coming in. And there's definitely a theme, and this is a question that's from Roger Eng. Hi, Roger, in San Francisco, and from Donald Perry, and also from James Grieve. I'm going to pull your questions together, and really that's around, first of all, is this something that every radiologist in your group is expected to do? And for the people who do it, how do you carve out the time for them to do it? How do you, if you're comfortable discussing, how do you structure your compensation perhaps, or your incentive schemes to make sure that their time is rewarded?
Right. That's a really good question. So within our practice, it's the culture of our group for those individuals who are interested in doing this or have the personality and so forth. And there, we try and make sure we have the right people in the group who are supportive of this and interested in this. So at one time or another, many members of this group have done that, depending on their specialty interest and so forth. We usually do it over lunch hour. Everybody in the group, most of the people in the group are aware that it's going on, and we all support it. We're not there. People support this because they know it's good for the practice and it's good for everybody. So we don't have that issue of counting RVUs or they're not doing their RVUs during lunchtime. They're not reimbursed. This is all just part of being a member of the practice, and we encourage people, if they have a particular interest of one sort or another, be it in CT issues, MRI issues, neuro, breast imaging, whatever, to convert that interest into participating in these programs. And there'll be many more along. So we hope to develop something for everybody.
That's great. That's great. Thanks, Bob. Another question, again from Donald Perry, was how you actually manage your referrals, and how do you make sure that you're going to the right groups and you're circling back to them at the right time? I mean, obviously we know that if it's a company and they're in sales, they're probably using some kind of customer referral management system. How do you guys do that?
Well, I guess it depends a lot on the topics and the issues. So, for example, with breast density and the new legislation in Pennsylvania that requires us to put certain things in the reports, and the many people's lack of knowledge of breast density, we felt we had to go out there and educate a lot of the primary care physicians and some of these specialists even too, like OBGYN, about breast density. So I'm not sure if I'm answering the question right, but there's an educational piece. A lot of it depends on the issue and the topic. So so that was because there was a new law coming down and new information about breast density. Now, sometimes it spins out of issues relating to dissatisfaction with a service or a desire for an improvement in the service or something. Maybe Carla could give an example on that.
As far as the breast density one, we took that one to the OBGYN practices, but also took that to the larger family medicine practices. We didn't go to, I can't say that we went to every, practice, but the really large ones and the OB, because that seemed to at least get most of the questions answered. We also have gone to different specialty practices, whether it be orthopedics or OBGYN, about our reports. If they had some dissatisfaction about reports, then we would get together with some of the key people of the provider practice and hash out what was missing from our reports, what did they want to see, what did they want to be more concise. And so many times it stems from feedback we're getting from whether it be someone in the office manager, because they're calling saying, Dr. X can't understand what the radiologist is saying here, So it's usually feedback from either new technology or feedback from the offices.
Yeah, lots of different pieces to that. Another piece too, we have a while back we had a quality bucket. The quality bucket was established so that medical staff, if they had any issues with the quality of the interpretation or issues with the report or whatever, they could drop a comment into the quality bucket, and that provided us with numerous areas of improvement ideas. So, for example, a pulmonologist felt that there was inconsistency among the radiologists using previous chest x-rays to the current chest x-ray, and they really wanted prior studies compared to the current. And that's a legitimate request, we thought, So also studies have shown that one of the common reasons for missing a subtle lung cancer is because the prior study, which is available, was not compared. Some academic studies years ago showed that. So we talked to the members of the group and said, listen, when you read chest x-rays, if there's a previous chest x-ray, we want you to mention it in the report and describe whether there's a change or no change from the previous study. So we implemented that across the practice, and oh man, the pulmonologists were extremely happy after that. And they really praised us up and so forth. So we're consistent with better quality reporting. That's just an example.
Great, thanks, Bob. So we have a couple of questions, one from Colin O'Brien and then one from Vivek Masson, basically asking, how many providers do you typically have at these meetings, and is there a limit? I mean, if somebody's in solo practice, will you show up and do this type of presentation for their group, for their office?
We will go anywhere.
Yeah, really. And by the way, we also take these presentations to patient groups too. So like there's a big breast cancer support group here, which I spoke to about breast density and all that. I mean, it's not just confined to medical staff offices and stuff. Some of these spin off into patient interactions.
But as far as the number of providers, we do not. I have never been to one where every provider was there. A good turnout would be maybe 75% of the providers. Usually it's somewhere between 50 and 75% of the providers. But the key there is you want to make sure you have the people who are most vocal be there. Great.
Moving on to your new program where you're potentially having the family practitioners and mid-level providers shadow you, Tim Swan had a question. Hi, Tim. Asking if you see this potentially evolving into a consultative role, or have you suggested to them that this is something they're probably going to need to use when clinical decision support becomes part of the Medicare program in 2017?
That's a great question. So, yeah, I imagine this is going to facilitate that, and it's very popular with the various mid-levels and primary care physicians that have been with me. They really like to do this, and I believe it will increase them contacting us. When I'm on call at night, I get calls from them, and they're saying, "Hey, Bob, can you check this case out? It's I was wondering what you think about this or that." So it's great. It gives us a chance to think we're more approachable, and it improves our communication with providers.
So, Bob, I'm going to actually ask a question of my own now based on what you just said, because one of the things that certainly as we go around the country with our Imaging 3.0 practice visit program and hearing you talk about this, can you talk about what these types of contacts with referring physicians and patients mean in terms of your professional satisfaction?
Well, for me personally, I greatly enjoy these programs, either with patients, some of them who are friends or people I've known in the community over the years, or who I've diagnosed the breast cancer on or whatever. A great deal of satisfaction with the patient groups. But in the medical staff groups, it's you develop a lot of friendships with members of the medical staff, people who you might not know at all. Suddenly you get to know the urologists better and the pulmonologists and various members of the medical staff. I think it's good for the culture of the group to interact like this. I think it's good for the medical staff to have radiologists doing their part to increase interactions among the staff. I mean, even among other specialties within the medical staff, the communications isn't like what it used to be. So whatever part we can play to facilitate dialogue between the parties is, I think, it brings me a lot of satisfaction. I think most of the members of my group, I'd say everybody does. Carla has a comment.
One thing I would like to add to that is I think it increases patient satisfaction, because the more of these discussions we have, the better the radiologists have gotten as far as interacting with the patients. And it makes for a much happier patient. The patient satisfaction has gone up.
Yeah, let me give an example on that one. Just recently at Cancer Conference, the oncologist was highly complimentary of the radiologists who are putting various measurements on the various CT scans and so forth of the tumors and this and that, but measuring it and texting it, putting comments on it. He said that he sits down with his patients and goes over these images, and he greatly appreciates the fact that the radiologists have annotated the images, because the patients, it tells the patients, this is the work of the radiologist. They've marked this up for you, for me to understand it, but look, you can see how helpful it is. So the patients can really see the role of the radiologist. But I didn't know that at Cancer Conference until Kevin said it. I was like, well, great, I'll pass that on to all the rads. We'll make sure we all do that technique. Just all these little things, it all helps.
That's great to hear. A couple of questions, some kind of housekeeping questions from Dharmashi Bhate, and asking, do you do anything on the web webinars like we're doing tonight. And then Emma Simpson had a question about, you talked about the quality bucket. Where did you put that? Was it an online bucket, or was there actually a physical bucket somewhere in the hospital?
No, so our PACS administrator established a button on the PACS stations that any of the medical staff use on the floors and so forth. And if they wanted to make a quality bucket comment, they would click on this button, and then they could put in, whatever the comment is. The radiologist didn't mention about this, or I wish he had said something about this, or whatever the comment was. And then we would collect those comments and then screen them to see what we can learn to improve from. So this was a way for the medical staff up on the floors or in their offices to just deposit comments, peer review sort of comments or quality improvement comments. And that was very helpful to us. So we haven't used it in a couple of years, but I've been thinking of getting it reinstituted again. We had a number of beneficial things from that. So it's an electronic bucket, so to speak. Geraldine, your other question was about the webinar. I didn't quite get that question.
Just wondering, have you ever thought about doing webinars like we're doing tonight? Obviously, the face-to-face is really important, but in terms of perhaps some of the groups that might not be able to attend that day, is that something you've given any thought to?
Yes. So we have a new technology that we're about ready to roll out. I'm involved with CME here, and it's called Blue Jeans, and this will allow a large number of medical staff, be it from their home, from their office, from their laptop, wherever, to be able to link in for a live webinar like we're doing tonight. And so this is a new technology that we're going to use with CME, as well as other uses within the health system. But I could see that technology also being used for webinars to broadcast things across our health system.
Great. So Colin and Brian had a question, and I'll add to it. But Colin's question was, do you ever encounter skeptics that say you're just being self-service, it's just a sales pitch? And are there skeptics in your group about the value of this program?
Yeah, I would say within every group there will be skeptics. So, or there will be some radiologists in some groups who this is just not their thing. They just, if they were to do it, they wouldn't be fully engaged and it wouldn't be as successful as others. So you really have to want to do this and be engaged. You want to work with the members of your team, the management team, and do it, do it for the benefit of the patients and for everybody. So yes, there are some skeptics.
Okay, thank you. Carla, do you want to add anything to that?
Yes, I do think that there are sometimes skeptics, and that's probably one of the reasons it's very important to get the more vocal people present at the meeting, because they will find that if they have a complaint, the best place to raise that complaint is face-to-face in a meeting where we can hash out what the problem is, and then, as I say, go back, in 3 weeks or 4 weeks and say, okay, is this going any better for you? Or have we fixed the problem? And you're not always going to convert them, but I do think that even in some of our most vocal providers, we have accomplished something.
One of the other themes I've also been saying, Geraldine, when I go to these sessions, is that radiology is changing. There's a new, I actually have been telling people that there's a new Imaging 3.0 program going on, and radiology wants to be more consultative, and we don't want to be doing inappropriate studies. Of course, that raises eyebrows. But, we really tell people that we do not want to be doing inappropriate studies. We want to be doing the right study at the right time for the right reason. And so we try and carry that as a subtitle message as we go out and meet with these various groups, to have them realize that radiology is changing and we want to be more interactive, and it's a good thing for everybody.
That's great to hear. I'd like to follow up that question and build on a comment from David Gruen. Hi, David, in Connecticut, saying that he's in a hospital where the emergency docs spoke loudest, and that resulted in outsourcing of radiology, and talking about the importance of the medical staff commitment to the radiology group. And I'd like to ask you to explore a little bit more the business case for this. How has this increased your influence with your hospital system how has it improved your standing in your health system?
Sure. So it has helped us a lot. Now, as a disclaimer, I will say I'm the medical staff president right now, and we are having elections coming up here in a couple of weeks, but nobody's running against me. Everybody is very happy with me, and it's given me a chance to also speak about radiology issues in general. So anyhow, I don't want to talk too much about the politics of all this, but it's been very helpful for our group to be visibly active in numerous committees and active in the medical staff. That's another imaging 3.0 piece that our practice also does, that and I've been trying to facilitate that to get members of my practice involved in the various key groups in the health system. So I think that's helpful. And I don't know, Carla, if you had any.
I think that, probably one of our biggest successes has been the breast density, and the number of breast ultrasounds per month has increased by probably 20%, and it's a lot of it has to do with us going out and explaining how much of an addition a breast ultrasound or maybe eventually an MRI is. And I think, yes, that's increasing the bottom line, but it's also giving a lot of patients a sense of everything's okay. It's helping their anxiety level after the mammogram. So I think that in both ways, both as a business sense and also, again, as for patients, it's helping a lot.
On the business side, so our contract has been renewed with our health system. The health system has absolutely no interest in having any other outside radiology groups, and here we have a fantastic relationship with our administration. In fact, the administration has told us that in the 30 years that our practice has been here, we are the only practice in the whole health system that has never had any major issues of any kind with the administration. Unlike all the other specialties and all the many other groups in the health system, they are very, very happy with the culture and attitude of our practice and our relationship with the health system. So, that's really a good thing. We are happy with that. Relative to the comment about the emergency room, I would encourage you, our practice is always out there looking to see if there's issues out there because we want to solve them. So these educational teams give us a great way one of the best ways to do it, but there's other ways too to solve the issues too. But
it is very helpful. Thanks, Bob. I'd like to follow up and get a little bit more into the culture piece. Adib Karam asked, how did you instill this culture? And I'm paraphrasing a little bit, but you clearly have a very strong culture in the practice. Totally understanding that there'll be some people for whom this is not their thing, but they still recognize the importance of it. Can you give any pointers to somebody who's perhaps listening into the webinar saying, I could never convince my group to do this?
Right.
How do you instill this culture?
Right. So a lot of it, so several pieces to this. First off, I think we are in a health system. People like Carla and the other members of the radiology department are fantastic people to work with, and I greatly enjoy working with her and all the other managers in our department here and also over at the other hospital. We have really good people and good staff, great staff. So a lot of it is a respect and appreciation of the people you work with and a desire together with them to do better service for your patients and for your medical staff. A lot of it is hiring the right people. So when we recruit, it's really important to recruit the right people for whatever your culture is that you wish to have. So we have a number of members of our practice who are very supportive and really like what we're doing and participate in this in various ways to help or support it. So but it's not 100%. We do the best we can, but you try and hire the right people, and you try and justify the reasons for these programs, how it's good for the group, and so forth. And when we hear positive comments from the CEO and other leadership, we share that with the group. We have an excellent relationship with the hospital administration, medical staff leaders, and so forth.
So we're running up against the end of our hour, and we've still got great questions coming in. Saravanan Kasturi had a couple of questions about interventional and what sessions you've done with that. So perhaps you could talk about some of the topics you've covered for interventional.
Interventional radiology is something we haven't developed as much for that. So now this goes back over a number of years. So we've had programs in years past when we had PET-CT, and we participated in the National Oncologic PET Registry in the early years. So we had programs about that. We've had programs with, this goes back a few years, multi-detector CT and the advantages of that. As we've had various things come along over the years, we've talked about the technology. We haven't done a lot with IR as much, and I guess that's just because of just, I don't know, various reasons. It hasn't been as much of interest, I guess, by various individuals related to that. So,
well, I would say, Saravanan, if you implement that in your practice, we'd love to hear how it goes. I think we're going to have to wrap up. We have 2 minutes to go. I would like to really thank Bob and Carla for participating on the webinar tonight, and also participating in writing the case study and the video. Your practice is certainly very inspirational, and Bob, you've certainly been an inspirational leader to me. I'd like to thank everybody who tuned in tonight, well over 100 participants, so really delighted to see the interest in how we as radiologists can change the perception of who we are and make that important contact with our referring physician and patient communities that makes them understand the value that we deliver. And then obviously would also like to thank our RLI colleagues and folks at Skeptics and Chris Hobson from the ACR Press for all the support and help in getting this webinar off the ground. So thank you very much. And with that, I think we'll close. Thank you, and keep your eyes open for the next one of these webinars. We'll be getting it scheduled soon. Thank you.